Hi, welcome to Cardiac MR Simplified. Today is the first Thursday of the week and it's mine of the month. Sorry, it's my turn. And we're doing the 208th snippet and it's called Pseudotumors. So I'm basically continuing what I had started last month, talking about cardiac masses. And this is in preparation of my talk in the IACI conference next weekend. So, what are pseudotumors? Pseudotumors are masses diagnosed on echo that sometimes, even on MR, may look like masses, but are eventually pseudotumors. And so, if you see this flow chart that I had made, we're still on the right side here. We finished variants and we're now going to look at pseudotumors. The variants, as I'd mentioned last time, we have crista terminalis, false tendon, moderator band, Coumadin ridge, and the eustachian valve. So let's run through the pseudotumors. They include four entities here: calcified amorphous tumor, vegetations, thrombus, and endomyocardial fibrosis membrane. The tumor protocol remains the same and is listed here. And here's the first pseudotumor, a 72-year-old lady who came for a preoperative checkup. Echo found a mass along the posterior mitral valve leaflet projecting into the LV, came for an MR. You can see the mass really well attached to the posterior mitral valve leaflet. It is bright on T1, doesn't enhance at all, and then the CT showed a densely calcified lesion here, which is why a CT is an integral part, a plain CT of a cardiac MR tumor protocol. And this is a classic calcified amorphous tumor of the mitral valve. It was first described not too long ago, but we are seeing more and more of it as people live longer. And when there is an appearance on echo that seems to reflect a tumor. And typically, the mitral valve is involved. Most of these patients are asymptomatic. Sometimes they may have surface thrombi. So, only if the patient is symptomatic is surgery indicated. And so, not uncommon, but CT helps us make the diagnosis. And I did this as case 18 when we just started about 3.5 years ago. And nothing much has changed since then. Now, this is the next one. A 39-year-old had an acute stroke, echo found nodules on the aortic valve, highly suggestive of vegetations. And normally that's good enough. You can do a transesophageal echo if required. But they were not very sure of what was going on, so asked for the MR. And you can see this lesion here attached to the anterior mitral valve leaflet along the ventricular side, which is consistent with the echo findings. Very heterogeneous appearance on T1. There's in fact three different densities on the T1 map, suggesting that this is a little more complex. And you can see that there is some enhancement because the late GAD shows a smaller, darker lesion than on the early enhanced images. But on the TI600, and I'll talk about this a little later, there is no change. So this almost suggests a non-infective thrombotic vegetation rather than a vegetation of infective endocarditis. So vegetations are nodules on valves. They have variable appearances. MR can rule out calcified amorphous tumor and other mimics, but papillary fibroelastomas are difficult to differentiate, though they're usually downstream. That means they'll be on the aortic side of the aortic valve and on the ventricular side of the mitral valve. And CT is sometimes superior, a cardiac CT, not a plain CT, to just identify vegetations. Now, this is a 27-year-old with a left MCA infarct, and a TEE 4 months ago showed a nodule attached to the aortic valve. And you can see this is a transaxial and this is a 3-chamber. On the transaxial, there is a 2-sinus bicuspid anteroposterior aortic valve, and at the posterior commissure, you can see this nodule, much better appreciated on the static images, which is consistent with the finding that was described on the TEE, which is 4 months prior, with no significant change in size. And that is unusual for a vegetation. So this is more likely to be a papillary fibroelastoma. It's also downstream, and that again goes in favor of this tumor. And that's about vegetation. So vegetations are excrescences or nodules on the valves, but they are usually not pseudotumors because they're seen on the echo, and there is rarely a reason to do an MR. I mean, sometimes when the cardiologist is not very sure of what is going on is when we get a request. The third pseudotumor is this. You have a 32-year-old man with a complex lesion in the LV. The apex is a little hypokinetic. Um, and you can see this attached to the apex, and it's a little mobile. So this is a typical appearance of a thrombus, and I got this summary done through ChatGPT. And basically, if you just further summarize this, thrombi occur adjacent to areas of akinesia or are attached to tips of catheters. They're always non-enhancing, and rarely when there's peripheral enhancement, you may get that with vascularized chronic thrombi. But the TI 600 images will be the same as the TI 280 or 300 images, and you should be able to make out that difference. Do remember that thrombi can occur on the surface of myxomas, so you have to be a little careful. So here's the first pass, and you can see that there is no enhancement of this lesion. The late CAT doesn't show enhancement. There is an infarct along the lateral wall. There is apical thinning. There is some calcification suggesting that it's a complex chronic thrombus, and that's a simple diagnosis. This is another patient who had a stroke, and you can see a silent apical infarct to which is attached this thrombus that is fluttering in the first pass study. This is a 52-year-old carcinoma breast on treatment, echo showed a mass in the right atrium, and you can see that it's kind of irregular, seems attached, but is mobile and shows features highly suggestive of a thrombus. But there was some difference between the early and late GAT. So you can see the early images show this thrombus not very well seen on the 2 chamber, but well seen on the 4 chamber. But then on the late GAT, some parts of it seem to be showing a little bit of enhancement, and you don't see this anterior projection very well. But then the TI 600 shows that it to be the same as on the TI 300 images, telling us that this is therefore definitely thrombus, and in any case the patient had this chemoport catheter to which the thrombi were attached. And then about 3 months later, the cardiologist called and said that they had completely cleared on echo after giving anticoagulants. If you had a myxoma, for example, you would find that the TI 600 shows a different appearance than the TI 200 or 300 image, telling us therefore that this is not a thrombus but a tumor, and this was an atrial myxoma. The last pseudotumor is this. There is a thrombus in the left apex on echo. It's not ECCO, ECHO. Classic triangular shaped appearance here. You can see that on the first pass. It's beautiful, and this is actually the double V sign. And that's very characteristic of endomyocardial fibrosis. This is another patient diagnosed to have biventricular hypertrophic cardiomyopathy for 20 years, but you can see clearly that there's an arrow-shaped or a V-shaped membrane, and you see the double V sign of biventricular EMF. So what's the double V sign? You get 3 layers: normal myocardium, thickened enhanced endocardium, and thrombus, and you can see that beautifully here. It is a condition, so endomyocardial fibrosis is where the apices show fibrotic tissue, often with calcification and or thrombus, and then you have restricted diastolic filling and a restrictive cardiomyopathy. And so the fourth pseudotumor is endomyocardial fibrosis membrane, and so that finishes off the mimics part. And the real tumors now I will do next month, all of them pretty much together, I guess, unless I'm going to split these up. I will decide depending upon the amount of material there is. But if you all are attending the IACI, then I will be presenting the entire talk in about 15 or 20 minutes and running through all of these entities. That's my WhatsApp channel. That's what started off everything. That's my Atmaswas book. And thank you so much for viewing this.